Now we come for the second part of the lecture. We will start with celiac disease. Celiac disease. Actual celiac disease is an immune-mediated disorder leading to the damaging of the proximal small bowel mucosa on exposure to the gluten or from the wet, rye, barley, and possibly also of the oats. The most common period of the presentation of the celiac disease is in the second part of the first year, but can be extended to from the 6 months to 2 years of the age, and it is a permanent intolerance of the to the gluten. The incidence is variable all over the world, ranging from 1 over 150 in Ireland, which is the highest, to the 1 per thousand other part of the Europe. Regarding the pathophysiology, it is thought that the part of the gluten which is responsible for the damaging of the intestinal mucosa is the glycine. This glycine is activated by a cell-mediated immune response to damage the villi. In general, it is a polygenic, multifactorial inheritance. There is an increased susceptibility to the celiac disease in the first degree relative, about 10%. Also, there is an increase in certain individuals with certain HLA, DQ2 and DQ8. There is an increase in certain disease, for example, diabetes mellitus, IgA deficiency, and Down syndrome, in addition to the viral factor. Exposure to the viral infection also might predispose the patient to the celiac disease. So we can see these factors probably direct us to the possibility of the polygenic inheritance. This is the gluten. الحنطة. Clinically, the most important clinical manifestation is the diarrhea, which is usually starting in the second half of the first year, which is the age of the introduction of the grain. Initially, the diarrhea is intermittent. Subsequently, it becomes continuous with a feature of the steatorrhea. During the celiac crisis, dehydration, the dehydration shock and acidosis also might occur. Anorexia is sometimes severe, and diarrhea might absence in this case. Sometimes the presentation just like that of the intestinal obstruction. Patient present with constipation, vomiting, and abdominal pain. Constipation generally caused by the anorexia, dehydration, muscle weakness, and bulky stool. Clinically, failure to thrive also might have a presentation. The onset of the diarrhea is usually accompanied by loss of appetite, failure to gain weight, and irritability. Weight loss is most marked in the buttocks and the limbs. The abdomen becomes distended. This is because of the gases and the fluid intestinal tract. Short stature might be the only manifestation. Sometimes the patient presents completely normal without diarrhea, without abdominal distension, without steatorrhea, without anything other than the short stature, and he proved to be due to the celiac disease. So in celiac disease, in short stature, screening for celiac disease is one of the important investigation. Anemia, vitamin deficiency. The anemia is usually caused by the iron deficiency, rarely by the B12 or folic acid. Fast-soluble vitamin deficiency is common. Rickets might occur when the growth is not halted by the disease. You know, when there is severe failure to thrive, there is no sign of the ricket because the ricket is a disease of a growing bone. Osteomalacia is common, and bleeding because of the hypoproteinemia secondary to vitamin K deficiency. Now we come for the silent celiac disease. There are a group of the children without any symptoms, but they are more likely to develop celiac disease. I mean, they are at more risk for having celiac disease. Those are with non-specific gastrointestinal symptoms, with growth failure, a condition that is might be linked to the celiac disease, for example diabetes mellitus والفيتيلايجو Down syndrome اللي حكينا عليها بالسلايدات السابقة, and also a family member of celiac patient. When we have in those group of the children positive serological tests, we do biopsy, and commonly we find in those asymptomatic children positive biopsy. I mean there is total or subtotal villus atrophy, and it is consistent with the celiac disease. بالرغم من انه هذول ما عندهم symptoms, we have to put them on a gluten-free diets. While if the patient, those group, sorry, not patient, the children, those group of the children who have negative serological test, there is negative serological or positive serological test, but negative biopsy, just follow up is needed without dietary therapy. راح ألخصها من جديد. عندنا group of the patient ما نسميهم patient بالحقيقة نسميهم children. They are more liable for the celiac disease. Those are with non-specific gastrointestinal symptoms. For example, patients with abdominal pain, with diarrhea without apparent cause, patient with growth failure without apparent cause, patient ما نسمي بالحقيقة هم هاي أكثر مرة نسميه نقول patient بس هو مو patient, هم children with condition like the link to the celiac disease, for example واحد عنده داون syndrome أو عنده diabetes mellitus أو عنده vitiligo, and أيضا family member of the child with celiac disease. Those if we do serological tests, if the serological test positive, we rush to the biopsy, and the biopsy commonly find abnormal result. We have total or partial villus atrophy. In these patients اللي هم عندهم positive serological test وعندهم positive biopsy لكن ما عندهم أي symptoms, the treatment is gluten-free diet. We have to put the patient on a gluten-free diet. While those children with these symptoms اللي عندهم negative serological test or negative biopsy, just follow up. This slide shows some of the manifestations of the celiac disease واللي هي common for the malabsorption and the abdominal extension and the wasting. The wasting commonly seen in the gluteal region, also in the upper. This is typical of the celiac disease. You can see the miserable face, wasting, abdominal extension, failure to thrive. Okay. We can see also an abdominal extension in gluteal region wasting. This is طبعا loss of the bulk of the muscle and loss of the subcutaneous. This is important slide. What we see in the practice, the celiac disease just represent the tip of the iceberg. This is also هنا silent celiac disease and latent celiac disease. شوفوا percentage is much higher than the symptomatic celiac disease. The silent celiac disease, there is abnormal mucosa, while the latent there is normal mucosa. Laboratory finding. As a part of the malabsorption, we sent for the fat content of the stool. It should be more than 7%, 5 to 10%. Commonly, you find it more than 15%. Impaired carbohydrate absorption and hypoproteinemia. Imaging finding كلها احنا حكيناها بال first part of the tutorial. Imaging finding, we can see flocculation, dilated small bowel, clumping or flocculation of the barium, basically loss of the continuity, loss of the normal pattern, I mean loss of the hustration. These findings بالحقيقة هي not specific for the celiac disease. Any case of the malabsorption we can find in the imaging of these changes. The most important investigation in celiac disease, that the common celiac disease without any doubt is the biopsy. We can see the normal, can see the villi, here the villi, okay, while if we compare to this, there is a flattening of the villi. هنا طبعا subtotal أو نسميه partial flattening, not complete flattening. Also there is infiltration of the plasma cell in the lamina propria, and lymphocyte, also intraepithelial infiltration of the lymphocyte. So there is total or subtotal villus atrophy, there is a plasma cell infiltration in the lamina propria, and intraepithelial lymphocyte infiltration. Okay, the same لكن صورة مقربة. You can see the total. طبعا deepening of the crivet أيضا موجودة هنا، هذا كلها بلازما cell and lymphocyte plasma cell infiltration. Regarding the serological tests, we have two tests, endomesial and antigliadine. Endomesial, also called tissue transglutaminase antibody assay. Both of them بالحقيقة has more than 95% sensitivity and slightly less specificity. بالنسبة للانتيجليادين, there are two types, the IgA and IgG. The IgA is more sensitive than the IgG, provided that the patient has no IgA deficiency. The differential diagnosis actually of the celiac disease, differential diagnosis of malabsorption in general. Any patient present with steatorrhea, with paratotroph, with agglomeration, with loss of the protein bulk, loss of the subcutaneous tissue, any cause for the malabsorption might be a cause for this presentation. فلذلك strict adherence to the diagnostic criteria is essential. The strict adherence is just by the microscopic changes and the clinical improvement on a gluten-free diet. Repeated mucosal biopsy to prove histological recovery on a gluten-free diet and relapse on a gluten change are not critical to diagnosis in the typical patients. شنو معنى هذه؟ سابقا كان when we suspect celiac disease, they do for first time biopsy to see there is changes of the celiac disease. I mean total, subtotal villus atrophy, plasma cell and lymphocyte infiltration. So when they diagnose, they put the patient on the gluten-free diet. After a while, I say after 6 months, they do not 6 months, sorry, for example, after 1 to 2 months, they do the second biopsy to see there is improvement in the intestinal mucosa, recovery, and the normal villi, there is no plasma cell, no lymphocyte infiltration. And after 6 months, they challenge the patient with gluten, and at that time they do another biopsy, third biopsy, to see if there is any change or not. This policy is abandoned. There is no need for multiple biopsies. Just the patient has the clinical manifestations of the celiac disease, have the biopsy changes, we can put the patient on a gluten-free diet. Regarding the treatment, the diet probably is the cornerstone of the treatment. This is by the gluten restriction for life. All sources of the weight, right, and probably must be eliminated during the initial treatment. يعني أي شيء يدخل به الحنطة should be abandoned. تعرفون الحنطة مو بس بالبريد، مو بس بالخبز، ممكن يكون بالكيك، بالبسكس. Should be abandoned, which is not easy decision. It is not an easy treatment. The child will struggle to have bread. We can substitute by something else, which is the rice bread. Lactose-free diet is recommended because extensive mucosal damage leads to the lactase deficiency. There is damaging of the cell that produces the lactase enzyme. normal amount of the fat vitamin should be given, and the clinical improvement is usually expected within a week, and histological repair within 3 to 12 months. Tissue transglutaminase, I mean the serological test decrease but not disappear completely. Corticosteroid might be needed in some patients with a crisis, very ill patient with signs and symptoms of the celiac disease, profound anorexia, malnutrition, diarrhea, abdominal distension, and hypokalemia. Sometimes we might need to give the steroid. Prognosis. Clinical and histological recovery is the role, but may be slow. There is a problem with malignant lymphoma of small bowel occur with increased frequency in adults with long-standing disease. Dietary treatment seems to decrease the risk for this complication. So when you put the patient with celiac disease on the gluten-free diet, probably we can decrease the risk for cystic fibrosis. بالحقيقة cystic fibrosis is the most common lethal genetic multi-systemic disorder in the Western country. Unfortunately, it is rare in our country. The incidence range from 1 over 3,000 to 1 over 4,000. It is a multi-systemic disease. Any part of the body, any system in the body can be affected. But the two most important symptoms is the pulmonary and the GIT. Cause morbidity and mortality. All patients develop obstructive lung disease associated with chronic infection that lead to the progressive loss of the pulmonary function. Now we come for the genetic of this system. Cystic fibrosis is autosomal recessive, and the gene responsible for the cystic fibrosis is located on the long arm of the chromosome number 7. This is called cystic fibrosis transmembrane contact and circulating. Cystic fibrosis transmembrane regulator protein. This gene is responsible for the movement of the salt and water across the epithelial cell, in and out the epithelial cell. And when I say the salt, I mean particularly or especially the sodium and chloride. The net result of this defect of the movement of the fluid and salt in and out the epithelial cell is the thick secretion, tenacious secretion. And this thick secretion is the cause for the most of the problem occur in cystic fibrosis. Cystic fibrosis is not a single mutation, it is many mutations, more than 100 mutations. The most common type were F508, and some of these mutations severe, some of them mild. That is why the cystic fibrosis range of the manifestation from mild to very severe. هنا احنا حكينا على الابنورمال thick mucus which cause the manifestations of fibrosis. This is the gene for the cystic fibrosis. In the clinical presentation, the patient might present in the neonatal period with signs and symptoms of intestinal obstruction, a condition what we call meconium ileus. This is occurring about 15 to 20%. The patient present with feature of the intestinal obstruction, abdominal distension, bilious vomiting, failure to pass meconium. This is because of the meconium stuck, which is thick meconium stuck in the narrowest part of the bowel, which is the ileocecal valve, leading to the meconium ileus. Previously, they do surgery for it to remove this meconium, sticky meconium, or probably a resection of the bowel. But nowadays, enema administration and radiological control is the preferred method for the treatment. 50% of the patients with cystic fibrosis in the infancy with failure to thrive, respiratory compromise, or both of them. The age of the presentation is variable. قسم من عندهم يوصل للأدلتhood وما حدا مشخصهم because of the mild manifestation. Newborn screening is important لأنه حتى نكتشف mild cases. This is by the immunoreactive trypsinoid gene, which is enzyme precursor, pancreatic enzyme precursor. This is a blood test. فتشوفون انه البرزنتيشن هنا is variable. Some of the patient might present in the neonatal period, some of the patient present in the adulthood. أكيد النيونيتال period هو الموست severe type والadulthood هو المايلد type. بيناتهم يصير الرينج of the severity of the cystic fibrosis. This is according to the type of the mutation. This is the meconium ileus condition. This is the thick meconium obstruct the ileum. Also, this neonate with meconium ileus, you can see the abdominal extension. Okay. Same patient with gas extension and the failure to pass gases in the rectum. الجاز in the rectum أو الجاز after delivery reach the rectum at the أو after 18 hours. So, patient present usually with gastrointestinal infection finding. Patient with untreated cystic fibrosis usually have abdominal extension and discomfort. They have steatorrhea and flatulence secondary to the pancreatic enzyme or pancreatic exocrine pancreatic insufficiency. Also, they have hypoalbuminemia, anemia, edema, and hepatomegaly. All the signs of the malnutrition might occur in patients with cystic fibrosis. There is what we call the meconium ileus equivalent. The meconium ileus equivalent usually occur in the older children, usually in the school-age children. They present with abdominal pain every now and then. This is because of the thick fecal material in the intestine, leading to the intestinal blockage. So intestinal blockage from insipid stool. التريتمنت بالحقيقة with laxative and enema and rarely knee surgery. They are more liable for the interception, especially in the appendix. The second system to be involved is the lung. Pulmonary findings include cough, tachypnea, rouse, and wheezes. Are the most common findings. Respiratory syncytial virus if occur in the early infancy will add to the morbidity. Those patients usually develop productive cough. Always they have productive cough in the adult because of the bronchiectasis. One of the most important complications of the cystic fibrosis is the bronchiectasis. Also, hemoptysis due to the bronchiectasis, exercise limitation, and carpulmonale. Common clubbing occur. About 25 to 50% of those patients, they do have reactive airway disease. The most common microorganism involving the lung are the Staph aureus and Pseudomonas aeruginosa. You can see here the normal lung, and this is the distracted bronchiectatic lung of cystic fibrosis. Clubbing. And this is the bronchiectasis, bilateral bronchiectasis. They should be bilateral because it is systemic disease. مو يجي واحد عنده unilateral bronchiectasis يعني cystic fibrosis. Unilateral بتكون بالlocal causes, for example, foreign body. Cystic fibrosis lead to the bilateral bronchiectatic change. Hepatic disease. بالحقيقة most of the patients with cystic fibrosis have cirrhosis at autopsy, but only small percentage they develop portal hypertension. Small percentage will develop manifestations of the portal hypertension in the form of the upper GI bleeding. لكن بالautopsy the majority of the cases have cirrhosis. The clinical finding may be severe with esophageal varices leading to the life-threatening gastrointestinal bleeding and hypersplenism requires splenic embolization. هاي بالحقيقة هو rare present. Now, for the reproductive tract, the majority of the patients they are infertile more than 95% because of the failure of the development of the vas difference. Some of the cases of cystic fibrosis might be diagnosed in the fertility clinic بالحقيقة هم هذول mild cases لأنه لو كان severe cases they present with pulmonary and GIT symptoms. In general, the female fertile, but she can't go to pregnancy because the pregnancy will make a considerable stress on the patient, limited pulmonary. In the diagnosis, we start with the neonatal screening. Neonatal screening depends on the immunoreactive trypsin gene in the blood. This enzyme is a precursor, pancreatic enzyme precursor. Sweat test is measuring the level of the chloride in the sweat. Any reading above the 60, this is probably a diagnosis of the diagnostic for cystic fibrosis. This test is done by quantitative bilocarbine antiphoresis, which they take a specific area in the body, especially in the arm, and they stimulated by the iontophoresis, and by the filter paper they collect the sweat and measure the level of the chloride. If the chloride more than 60 milliequivalent per liter, this is diagnostic for the cystic fibrosis. In the treatment, the cornerstone of the treatment of the gastrointestinal treatment is the pancreatic enzyme supplementation. The problem is the affection of the pancreas with the deficiency of its exocrine enzymes, which facilitate the absorption, intestinal absorption of the nutrient, especially the fat and fat-soluble vitamin. So we have to supply the patient with pancreatic enzyme. Also, sometimes we add antacid to increase the absorption. The patient needs to have unrestricted diet. She should have all the fat and fat-soluble vitamin. There is no need for the restriction. Caloric supplementation also should be provided with high caloric commercial supplementation or formula or food model, including glucose and medium-chain triglycerides, are also added to the patient diet. So caloric supplementation should be met. The goal of the nutritional therapy to achieve normal height and weight. In cases of the respiratory management in cystic fibrosis, the most important two things is the clearance of the airway. This is by the posture drainage and physiotherapy, and aggressive antibiotic therapy. There are two medications commonly used. These include the pulmozymes, which is the inhaled recombinant human DNAs, and inhaled tobramycins. These actually a promising drug, and they maintain lung function and reduce the need for the hospitalization and IV antibiotic. Airway clearance treatment. This is by the posture drainage, chest percussion. The idea, when we do the chest percussion, the mucus will move from the small to the large bronchioles, and when it is reached large bronchioles, bronchioles and bronchi, it will be cleared by the cough. Bronchodilator and anti-inflammatory therapy are also frequently used. Corticosteroid sometimes might be used to maintain the lung function, but have a major side effect, hospitalization. This is because the patient has bronchiectasis and most of the time have difficulty in breathing, increased sputum production, decreased exercise tolerance, and diminished function. This is the posture drainage. You can see here the percussion. The percussion, this will move the secretion from the small to the large bronchiole, rendering it more available for the action of the cough in order to expel the secretions outside the lung. This is another one. This is postural drainage. Postural drainage. She used the gravity to move the secretions together with the tapping in order to make the secretion moving from the small to the large bronchioles. Prognosis. Rate of the progression of the lung lymphoma usually determines survival. Most patients now reach adulthood. In overall, بالحقيقة the prognosis depends on the severity of the cystic fibrosis. Some of the patients died early in the life. Some patients reached the adulthood with minimum manifestation. Lung transplantation بالحقيقة هي end stage treatment, and now it is probably accepted treatment. Gene therapy is still a trial. Thank you.